Well, thank you very much for that kind introduction. Good morning, everyone. I must say it gives me great pleasure to be here in Bahrain. This is my first time, actually, to be here. And so far, I've been here for around 10 hours. It's been a fantastic experience. So thank you very much. Also, I would like to thank the organizers who helped with my movements and booking the tickets, Reem and her team. Right, so I think we are slowly getting people back in. So I will start at a slow pace. This is my disclosure slide. And one thing that I need to tell you that given the topic, it can be quite dry. So I try to supplement it with a case. And we're going to discuss the case and see how things go from there. Now, if you think about diabetes and life expectancy, the moment somebody is diagnosed with diabetes, their life expectancy is reduced, right? So there's a reduction by around 6 years. And if you have diabetes and a previous myocardial infarction, life expectancy is reduced by 12 years. Diabetes, MI, and stroke, 15 years reduction in life expectancy. So it's an issue. And we know that the majority of our patients die of cardiovascular complications. Now, to prevent cardiovascular disease, you need this multifactorial approach. So you need to address hypertension, hyperglycemia, dyslipidemia, nephropathy, as well as thrombosis potential, i.e. blood clotting. And of course, a lot of our patients are overweight. Now, bearing that in mind, let's start with a case. So we've got Alice, who's a 61-year-old lady, type 2 diabetes for 3 years. Remember, when ladies get diabetes, they lose the cardiovascular protection that they usually have. Now, complications, she's got hyperlipidemia and hypertension. She's on metformin, statin, and ramipril. That's her BMI, 32, blood pressure, well controlled. HbA1c is excellent, 6.5%, total cholesterol 3.9 with an LDL of 2.4, eGFR not bad, and her liver function, other than a very mild elevation of ALT, is pretty normal. So a question for you, should we start her on an antiplatelet? Should we start her on aspirin therapy to give her cardiovascular protection? And that might sound like a very simple question, but actually the answer is a bit more complicated. And the only properly powered study that looked at primary prevention with aspirin, when I say primary prevention, is prevention of cardiovascular disease in people who did not have a vascular event before. So the only study is the ASCEND trial. And the ASCEND trial had good numbers, more than 15,000 patients. And what it showed that if you give aspirin for primary prevention, you're reducing vascular events by 12%. But there was an issue with bleeding. And actually, when the study was presented, and I can't understand why, it was always presented in a negative way, that actually the study is not great, you shouldn't give aspirin because you're increasing bleeding. But actually the benefit to harm ratio is 1.2, so the benefit is positive, okay? But of course, you want to know, what do the guidelines say? What are we advised to do with these patients? So before I go into the guidelines, I just want to remind you of the classifications. So when you have a class 1 recommendation, that's definite, is recommended, is indicated. If you have a class 2, it could be a class 2A, should be considered, or a class 2B may be considered. And then you've got 3, don't do it. So 1, definitely do it, 3, don't do it, and then the 2, you should or you may consider. And then you've got the level of evidence. A, very strong evidence. B, good enough evidence. And then you've got C, which is really a chit-chat between experts. So that's the lowest level of evidence. So if you have a class 1, level A, then it's very, very strong. So what do the guidelines say in relation to primary prevention? They divided diabetes patients into moderate, high, and very high risk. So the moderate risk, people with less than 10-year duration and younger people. And then you've got the high risk with at least one risk factors and you've got very high risk with end organ damage, like nephropathy, for instance. And this is what they said. So in patients with diabetes at high, very high risk, aspirin may be considered. So the evidence is a 2BA. So the level is high, but it's a may be considered. In patients with moderate risk, so these are the sort of lower risk patients, you should not use aspirin. And the other thing that they say that offer gastric protection, so you should consider gastric protection with a PPI to reduce the risk of bleeding. By the way, in ASCEND, people on PPI were only a quarter, so it was relatively low level of use of PPI. Now, the second question in this lady, does she require intensification of statin therapy? So if you think about it again, the guidelines say that in people with moderate risk, this is sort of the lower risk group, LDL target should be less than 2.5 millimole per liter. If you have a high risk, 1.8, and the very high risk is 1.4. So you've got 3 different LDL targets. So if you have somebody who is very high risk, who had an MI, you really need to go to the LDL of less than 1.4 millimole per mole. They also mention non-HDL cholesterol. Most people actually, in my experience at least, don't look at that, but that is mentioned here as well. Statin is always your first line. If you can't control LDL with statin, you add in ezetimibe. Now, if the statin is not tolerated or you're not reaching target, then you can consider a PCSK9 inhibitor. And of course, statin should not be used in pregnancy or in ladies with childbearing age. So just be careful how you manage, and you really need to be aggressive with the LDL in very high risk patients. Now, one thing about statin intolerance, we hear that a lot. Actually, it's overestimated. There are ways to make the patients sort of have less side effects by starting a very small dose of the statin every other day and then pushing up the dose later on. So most people actually tolerate the statin if you're patient enough. Now let's fast forward. So this is Alice now, 6 years later. She wasn't started on aspirin because she was deemed to be low risk or moderate risk. You know, she had diabetes only for 3 years. But what happens to Alice 6 years later is that she's admitted to hospital with chest pain. She's now aged 67. She's on metformin, she's on gliclazide, atova, ramipril, and aspirin. Now, this is her BMI, that's her blood pressure. Look at the HbA1c, incredibly impressive at 40 millimole per mole or 5.8%. Her LDL is 2.6, the eGFR is 67, and her ALT is very similar to previously. It was 48, now it's 52, but otherwise normal LFTs. That's her ECG, and as you can see, she did have an inferior myocardial infarction. Now, this lady had a CGM because she was part of a study, and to our big surprise, she was having very significant hypoglycemia. This is somebody who's not on insulin. She's only on gliclazide and metformin. Each red dot is hypoglycemia. She's running more than 50% of the time in hypoglycemia. Now, hypoglycemia is best avoided in diabetes, particularly high vascular risk patients. And this is a study that I quite like, that looked at the relationship between severe hypoglycemia and outcome. So on top, you have MACE, major adverse cardiac events, and in the bottom, you have death. Now, if you have a severe hypoglycemia within a week, your risk of MACE and death is increased greatly, as you can see. It's more than 10-fold increase. But what's very interesting, that the risk is still there up to a year after this hypoglycemic event. So it's not that you get hypoglycemia and your risk is there for a few hours or a few days. It is there for a long time. So do not underestimate hypoglycemia. And this is a study from our region. This is a study from Leeds and part of Yorkshire, which was conducted. And this was about ambulance call out for hypoglycemia. So it was hypoglycemia severe enough for the ambulance services to be called out. And we looked at the type 2 diabetes group and we adjusted for age. And what we found that mortality was 14% within a year of the hypoglycemic event. Very high mortality, which was identical to mortality in people with type 2 diabetes following myocardial infarction, which is the red column. And as I said, this is adjusted for age because what we've done, we excluded people above the age of 75 to exclude frailty as the cause. If you include those, the mortality was 24%. But the most interesting bit is that actually you can modify this mortality. So we did conduct a study, again it was local study, looking at nurse-led intervention. So people with severe hypoglycemia, then the nurse will contact them every 2 weeks for a period of 3 months. So it was intensive contact for 3 months, and then very light touch for up to a year. Patient had access to the nurse. What we found that in people where the nurse contacted them, did education, made sure that they are checking their glucose, mortality was reduced significantly. I was quite surprised actually at the results, and that was because of a major reduction in cardiovascular mortality. Right? The numbers are small, it was only 150 patients, but the follow-up was quite long, as you can see here. Now the question is, do you think that we should use CGM, post-acute coronary syndrome? Is that a good strategy? Because a lot of hypoglycemia you don't know about, you really don't. And this is a study that we conducted that was published earlier this year. We used the Libre device, post-myocardial infarction. The study had 141 patients, half were on insulin, half on sulfonylurea, in addition to any other hypoglycemic therapy. The red is the flash glucose monitoring, and the blue is SMBG, self-monitoring blood glucose. As you can see, it's a bit disappointing, isn't it? The HbA1c falls at 90 days, in 3 months, falls by 7 millimole per mole, but there is no difference between the two groups. However, and this is really important, if you look at hypoglycemia, there was a massive reduction in the flash glucose monitoring, more than an hour difference, and that was consistent across people who were initially on insulin or on sulfonylurea. So the take-home message is that if you use flash, or any form of CGM for that matter, post-myocardial infarction, you're reducing HbA1c safely without too much hypoglycemic exposure. So what happened to Alice? So Alice was managed with a stent, right coronary artery stent, and of course the question in our mind, did that hypoglycemia contribute to her MI? I don't know. Might have, been possible, quite possible, but we don't know for sure. Her non-glycemic medication of discharge, you can see it here. She's on aspirin and ticagrelol as dual antiplatelet treatment. Glycemic medication, would you keep her on gliclazide? And I think you probably would say no, and that would be the right answer. I definitely wouldn't keep her on gliclazide because you want to go for cardiovascular protective agents. If you look at the guidelines say that SGLT2 inhibitors, EMPA, CANA, or dapagliflozin should be used in people at high cardiovascular risk. And empagliflozin has been shown actually to reduce mortality. Also, GLP-1 receptor agonists are quite powerful as well. And remember, these two agents work completely differently. So one is an anti-atherosclerotic, that's the GLP-1 receptor agonist, and the other one modulates the hemodynamics of diabetes. So if you want perfect protection, you probably need to use both. Now, when it comes to metformin, it should be considered in overweight patients without CVD at moderate risk. Now, a lot of people would say that metformin has got evidence for cardiovascular protection. Strictly speaking, it doesn't, because there hasn't been a randomized control trial with metformin. The only data we have is a sub-study of the UK PDS that was published many decades ago. Now, gliclazide was replaced with SGLT2 inhibitor. Alice is reviewed 3 months later. Cardiac echo, normal LVF. Really important because people with diabetes have got impaired LV function and the prognosis gets really bad once they have that. Blood pressure, lovely. LDL, look at the LDL, 1.3, below that 1.4 because she's really very high risk. A1C, very nice. I'm quite happy with that. Or metformin and empagliflozin. Are we worried about hypo? Not really, because these agents do not cause hypos. eGFR reasonable, BMI dropping. Remember, she started with a 32, so 29 is not bad. And then she was discharged, and general practitioner was asked to continue dual antiplatelet treatment for a year, followed by aspirin alone, which is standard therapy. But do you agree with this course of action? Is there something else that we can do to offer maximum protection? And here comes the Pegasus trial. So the Pegasus trial looked at extended dual antiplatelet therapy with aspirin and ticagrelor, but low-dose ticagrelor. And this is what it showed. So the solid line is diabetes, the dotted line is people without diabetes, green is people on placebo plus aspirin, and that other color that I can never remember what it's called, is aspirin plus ticagrelor, right? So you can see whether you have diabetes or you don't have diabetes, the combination of aspirin and ticagrelor is better than aspirin alone following myocardial infarction. What was very interesting, if you look at cardiovascular death, there was no difference in the non-diabetes group, but in the diabetes group, that combination reduced cardiovascular death. So extended dual antiplatelet treatment has got beneficial effects provided bleeding risk is low. And remember, that's really important because you need to weigh the risk and benefit. Now, another complication here, on further questioning, she appears to be complaining of pain in her calf muscles on minimal exertion. The dorsalis pedis is weakly palpable on the right and no pulse is felt on the left. Tibialis posterior not palpable right or left. The vascular ultrasound confirms diffuse peripheral artery disease. Now, you know, once they get peripheral artery disease, their risk just shoots up big time. So would that push you towards a different course of action in relation to antithrombotic treatment? And actually, here comes the COMPASS study. So the COMPASS looked at aspirin alone or a combination with rivaroxaban, low-dose rivaroxaban or rivaroxaban alone. And what they showed that if you use rivaroxaban and aspirin, low-dose rivaroxaban that is, it's much better than aspirin alone in people with established cardiovascular disease. So it reduces the primary endpoint of myocardial infarction, stroke, or cardiovascular death. There was indeed an increase in bleeding, but even if you take that into account, there was a beneficial effect in these patients. So when you have somebody with peripheral artery disease, diabetes, who had an event, established coronary artery disease, I strongly advise you to go for a combination of aspirin and the anticoagulant in the form of rivaroxaban. The other thing is when they analyzed the peripheral artery disease subgroup on its own, what they found, if you focus on the left, there was a reduction, sorry, on the, is it the left or the right for you? The right. You get a reduction in peripheral artery disease major event in terms of amputation. So one thing that I wanted to point out for you is not all about antiplatelets. Clot lysis, i.e. the fibrin network, is very important, and this is our work showing that cardiovascular mortality increases with longer clot lysis in people with and without diabetes. So targeting the coagulation factors can be quite important in people with diabetes. So what about the guidance? Aspirin is recommended for secondary prevention, that's fine. Treatment with P2Y12 receptor in form of ticagrelor or prasugrel is recommended in people with diabetes following an event for up to 1 year. Use a PPI with it to reduce the risk of GI bleeding. And if you can't use aspirin, you can use clopidogrel long term. Now, prolongation should be considered. So a dual treatment, dual antiplatelet treatment should be considered in high-risk patients in the presence of low risk of bleeding, and then addition of an antithrombotic drug to aspirin for long-term prevention should be considered without high risk of bleeding. So it's a 2AA recommendation. And if you want to read about thrombosis and the use of antiplatelet anticoagulants in diabetes, there's a review article that we published. It almost killed me, but I think we try to be as comprehensive as possible. So in the last few minutes, I just wanted to show you something interesting that happened to this lady. Her HbA1c rose to 63 millimole per mole. It was 54 before, so a rise of 9 millimole per mole. She says no change in lifestyle, feeling tired, but no other symptoms. And she was on flash CGM. Time in range actually did not change. We could not understand why the HbA1c got up so much, and her time in range remained more or less identical. Given her age, so the options are that where you say, well, it's good anyway, let's just leave it as it is, or look into it in more detail. And I like to look into things in more detail when I don't understand what's going on. And actually what happened here, she's on a combination of antiplatelet anticoagulants, and she had iron deficiency anemia. And with iron deficiency anemia, your HbA1c can go up. It's not a real reflection of glycemia. And it is quite common, and I see quite a lot of cases like that. So remember, unexplained rise in HbA1c, consider iron deficiency anemia. And the reason for that is a prolongation in red cell lifespan, something that I'll talk about this afternoon. So when it comes to managing patients, complicated patients with CVD and diabetes, I believe you need a multidisciplinary approach. And we indeed have a cardiometabolic clinic where we have a cardiologist in the bottom right, and we have 2 pharmacists with us. And that cardiometabolic clinic really helps the patient, helps to optimize the treatment of this patient. They don't go from one clinic to another. This is something that we established around 18 months ago. And I learned a lot from the cardiologist. Cardiologists learned from me, so it's been absolutely fantastic. And what we're trying to do is to change this trend. So if you look at the use of SGLT2 is the greenish color, and the GLP-1 receptor agonist, which is the orange color in the UK, the change is very little, and there is no difference in people with and without cardiovascular disease. So this is something that we need to work on. So to conclude, reduction in CVD diabetes requires a multifactorial approach. Management is definitely getting more complex, and therefore a multidisciplinary team can really help here. The interaction can help. When it comes to lipids and blood pressure, targets are relatively clear. We know what we need to do. Glycemia, this can be far more complicated to manage. Hypoglycemia is best avoided, and the type of hypoglycemic agent use can be very important. When it comes to antithrombotic therapy, primary prevention is largely dependent on risk assessment. So it is the decision of the healthcare professional in discussion with the patient. Dual antiplatelet treatment is required following a cardiac event, usually for 12 months. There are, of course, exceptions. Longer dual antiplatelet treatment or combination of antiplatelet and anticoagulant should be considered in high thrombosis and low bleeding risk patients. Thank you very much for your attention.